This program is brought to you by Emory University.
Good morning, everyone. Welcome to Heart and Vascular Grand Rounds. Our speaker this morning needs no introduction. It's Dr. Tanveer Rab. He is the Chief of Cardiology and Director of the Cardiac Catheterization Lab and Director of Interventional Cardiology at Emory Decatur Hospital. He served on the Joint ACCHA Guideline Writing Committee and is currently on the Communications Committee and Bifurcation Club of SCAI. He's a member of the ABIM Examination Writing and Approval Committee for Interventional Cardiology, and he is the host of the monthly webinars for the SCAI Bifurcation Club. He's a very high volume complex PCI operator with published clinical and research interest in left main bifurcation stenting, as well as coronary atherectomy procedures, cardiac arrest, and cardiogenic shock. Today, he's going to talk to us about out-of-hospital cardiac arrest. So, Dr. Rab, good morning and welcome.
Thank you very much, Pratik, for the kindness. So, for about 15 years or so, I've had this interest in which patients who have had out-of-hospital cardiac arrest should go to the cath lab. So my topic today is really based on out-of-hospital cardiac arrest related to acute coronary syndromes. I have no disclosures. So here's the data. This is the #1 cause of death in the United States, with about 360,000 deaths per year. Only 10% survive if they make it to the hospital. About 74% have arrest at home, 15% in the public settings, but 50% is unwitnessed. So this is a disease that strikes an individual sometimes very early in the prime with a lot of mortality and morbidity. And there's really no, the needle hasn't really changed much in the past 20, 30 years and how to make the survival better in these patients. This is a significant public health problem. And I'm surprised that we don't address this like we had addressed the COVID pandemic and how to reduce these unexpected deaths in the community. As I said, most cases are due to acute coronary syndromes caused by plaque rupture. Oftentimes, when they reach the hospital, interventional cardiologists called on patients with this disorder as to who should go to the cath lab and make a decision at that time. So the only 10% who survive, and I call them the 10 percenters. These are patients who achieve return of spontaneous circulation, or ROSC, and are hospitalized. And the rate of survival to discharge with good neurologic function among these patients is between 0.8 to 20%. Remember, the plaque rupture causes the acute event, which is arrhythmic VT-VF, and you can fix the artery, but if the downtime is long, these patients die because of a neurological dysfunction or multi-organ failure. So it's not the PCI that causes death. You actually salvage the heart. It's actually a neurological outcome that's poor. And these patients are left with a lot of morbidity at home. They're not able to go back to work, and their neurological function is really impaired. And many of these patients, if you think of a household, if a young person has a cardiac arrest, I mean, the fact is the main breadwinner, particularly in rural communities, cannot provide that for the family. 2/3 of the patients with out-of-hospital cardiac arrest died due to anoxic brain injury, another 1/3 due to refractory post-arrest shock and multi-organ failure. So recently, there's a publication actually out of Japan that showed that risk factors out-of-hospital cardiac arrest with a young patient, those with renal disease, large infarctions, if you had a chronic total occluded in one vessel, let's say the right coronary artery and the LAD occluded, that would be a high-risk patient. And left main or left main equivalent, such as I had one on Christmas Eve, both the origin of the LAD and circumference occluded, those patients will have a higher risk of death. In terms of good survival, small infarctions, good renal functions, if you have a shockable rhythm, and if you don't get on ECMO, for example, you have a better chance of survival. So if you have out-of-hospital cardiac arrest due to shockable rhythm, be it ventricular fibrillation or ventricular tachycardia, if you achieve ROSC, 1/3 of these patients will have ST elevation infarction. The rest, there's no ST elevation. And in ST elevation myocardial infarction, there is significant coronary disease with an acute lesion, about 80-90% of cases. Those with non-STEMI also have coronary disease, but acute lesions are seen only in 1/3 of the cases. For refractory VT and VF, the acute lesions are more prominent, also both in STEMI and non-STEMI. So what do you do for resuscitation? So if you look at the CARES registry, I'm glad Brian McNally's on the call. He is a real gem at Emory, works out of the ED department and has put on and leads the National Cardiac Arrest Registry. And this is data from his registry. All states are not enrolled in this. Out of 139,000 cardiac arrest patients, in his registry, 41.2% received bystander CPR, but survival was only 10%. If we look at the bottom here. In Georgia, for example, we have a reporting system. We had about 5,000 cardiac arrests in 2022, but the majority, about 4,000 plus, died. Survival rate was 14%. And if you look in Georgia, the bystander CPR was low at 24.7%, but nevertheless, the category of patients survived was still in the 10% range. If you look at rural communities versus urban communities, particularly in the ages between 25 and 64, the mortality in rural communities, particularly in rural Georgia, is 1.5 times compared to big cities. So both the ACC and HA have put out this CardioSmart publication, and there are 3 steps that need to be taken. Number 1, if there's a patient with cardiac arrest, call 911. Number 2, start CPR, hands only. You don't have to do mouth-to-mouth resuscitation, the current algorithms of CPR resuscitation. And most importantly, if you have a defibrillator available, provide an external shock to the patient. So these are 3 steps that both the ACC and HA focus on. If you look at bystander CPR compared to EMS, just because an ambulance takes a long time to come to the patient, waiting an ambulance, the death rate is very high. Good quality CPR is very important. I can tell you, I recently had a MARTA bus driver, started having chest pain, felt lightheaded, actually pulled his bus to the side, and the passengers realized what was happening, gave him good quality CPR, but unfortunately, he still died. But the quality of CPR is very important compared to EMS. So if you have a bystander CPR versus EMS arrival, you have better survival and better neurological outcomes if the CPR starts right away rather than waiting for an ambulance to come to the door. If you look at CPR duration survival, there's a time curve. Less than 16 minutes has a favorable prognosis. Greater than 30 minutes has poor survival, but mortality rates very high with only 1% expected chance of living through the event. Now, AEDs are really important. If you can defibrillate somebody within 4 minutes, there's 60% chance of survival. Up to 8 minutes, additional lives are saved. But if you wait for an ambulance to serve, you become in the 10% range. Then if the ambulance arrives between 10 to 12 minutes, and certainly Atlanta has very delayed times of ambulance arrivals, the survival rate really goes down if you wait for an ambulance to show up. So AEDs, automatic external defibrillators, are very important to save lives and actually prevent morbidity in this patient in the long term. So AEDs are now available in the United States in many places, such as schools, workplaces, shopping centers, sports facilities, airports, government buildings, community centers, public libraries, some beaches. And the Food and Drug Administration actually allowed over-the-counter sales of these. You can go on Amazon and buy this, but they're really expensive, like $1,400 or so. At the present time, many companies are looking at disposable AEDs that would cost about single-use disposable AEDs, delivering at least 3 shocks to the patient, and to cost around $200 or so. So the Georgia chapter of the American College of Cardiology, and I'll give a shout out to Jonathan Kim, was really very important in helping pass this bill, Georgia Bill 874. The House of they passed this bill requiring all Georgia high schools that participate in interscholastic athletic programs to have one AED on site. It also requires staff to be trained in CPR, AED training, etc. And this will be applicable to all Georgia public schools, K to 12. Now, Jonathan wrote a great paper. This is a digression on a review of sudden cardiac arrest and death in athletes. And this is really something that you all ought to read on. It's really well written and really addresses the issue of high school athletes who have cardiac arrest, which generally is not ACS related, but just want to bring it up. The American College of Cardiology, the American Heart Association, and again, Jonathan had a big hand in this. They put up this bill that's passed through Congress at the end of 2024, known as the Cardiomyopathy Health Education Awareness, Research and Training Schools, or the HEARTS Act. And basically, it was very similar to the Georgia law. The law will help teachers and students become better able to respond to cardiac arrest. The law will provide training CPR and the use of AEDs and the purchase for U.S. schools. And the big thing, the Buffalo Bill safety, Damar Hamlin, who had the live TV cardiac arrest, was a big supporter of this law, which went into effect. So thank you, Jonathan, and support for the American College of Cardiology, both locally and nationally, in making this possible. So the next question is, the patient has survived. He's a 10% who has survived, who has achieved ROSC. Where should he be taken to? A small study from Germany showed that if you go to hospital PCI capability, your 1-year survival is increased. And if you have an ambulance that transports you in 6 to 10 minutes, but if the ambulance takes you to a non-PCI hospital, such as the rural hospital, you have a very high mortality, as the black line here. But if you go to a PCI capable hospital, then your survival will improve to about 40% or so. So in the European guidelines, it is recommended as a class 1 that healthcare system implement strategies to facilitate transfer of all patients in whom HCA is suspected after ROSC to hospital offering 24/7 PCI. So here's the goal. If you have STEMI, if you're a patient who should go to the cath lab, what you're preventing is extension of your infarction, progression to cardiogenic shock, progression to arrhythmic events, but really doesn't take away from neurological dysfunction if there's a delay. So that's why the guidelines are here, that if you get PCI quickly in an appropriate time interval, you improve your cardiac survival, perhaps your neurological survival as well. The time window is very important. I'll digress again, that if this is SCAI classification of shock, which goes through A to E, E is the extremist, where the patient have both cardiogenic shock and cardiac arrest. And 25% of patients SCAI cardiogenic shock E group also have cardiac arrest. If you look at the time delay, if patients survive, the first 24 hours is very important for assessment and aggressive treatment. But if you go up to 72 hours, most of the patient would have died. If you have a patient, say, in rural communities who've had arrest or shock and need to be transferred, guess what? The average time delay is 2.8 days. If you have arrest and shock and you get the device in a hospital that has advanced support and care, these patients, you will get a device, but your morbidities, other things that will happen to you include the chance of receiving an ECMO, have a kidney failure, go on have a hemolysis, may have stroke, a lot of transfusion and device-related infection. So increase your complication rates just by delaying the arrival of this patient for 2.8 days. And this is really a huge problem, getting people over from our rural communities. So in 2017, with the Georgia chapter of the American College of Cardiology and the leaders at that time approached the Georgia Congress and Senate to approve the Georgia Senate bill for emergency cardiac care centers, of which Emory is a participant. So level 1 centers are basically those who provide 24/7 PCI, have open heart surgery backup, can do temperature management, have LVAD access, neurologists on board, etc. Level 2 is someplace like Emory Decatur, which has a 24/7 PCI, gets temperature management, has LVADs. But if you need a higher level of care, for example, upgrade to a 5.0 microaxial flow device or ECMO, you need to transfer to level 1. Rural hospitals basically can provide temperature management, but really need to rapidly transfer these patients to a level 1 center. And the law was really written for rural communities to bypass these rural hospitals and go straight to a tertiary care center. Unfortunately, the law did not enforce it on ambulance services, and ambulance services still take patients to the nearest hospital, which is in rural communities, rather than bring them to tertiary care centers. So the law in principle keeps this registry of this data, from which all the data that I showed you earlier, but enforcement through EMS is not possible. And I wish it was, because it would avoid a lot of problems that these patients have, and young patients may actually have a chance to survive if they come to a tertiary care center. So in 2018, we wrote this paper, and we thought we would merge designating emergency cardiac care center and also make them known as out-hospital cardiac arrest or cardiogenic shock centers. And again, we took the 3 levels of care to state that the level 1 is those with advanced MCS, as shown. They'll have dedicated cardiac shock care centers. The level 2 will be someplace like Decatur, STEMI receiving PCI hospital, which has advanced MCS, and level 3 will be rural communities. I want to digress again and talk to you about the SCAI classification shock, which goes through a pyramid from A through E. A is a person who may be pre-shock, like a proximal lesion, has a high EDP, but is not in shock yet. B is somebody who has hypertension with tachycardia, is not on inotropes yet. C is classic shock, which requires inotropes and is thought about giving a mechanical circulatory device. D is somebody who's deteriorating, definitely needs an MCS device. E is somebody who's an extremist, his chance of survival is very low. And again, the levels of designation fall in the same way. Level 3, patient A can land there. Level 2 is really a cardiac care center, which also provides primary PCI and MCS. And level 1 is again advanced center. The important thing to note is that if patient in the SCAI shock E who also have cardiac arrest, they have a 55% death rate at 72 hours. So the preferential transport of these patients should be to a level 1 center or level 2 center which not only provides PCR, but has advanced MCA support available. The paradox came with a trial out of Europe, also known as the ARREST trial, where they showed that those patients who did not have ST segment elevation, expedited transfer of those ARREST patients was not associated with a decreased 30-day mortality. So my take on this is that these patients who have no ST segment elevation should be transferred, but not the same urgency as those with a STEMI and cardiac arrest. The third part is which out-of-hospital cardiac arrest patients should go to the cath lab. So we need to, and both the American Heart Association document that came out about taking care of cardiac arrest and cath lab last year, and European guidelines, both now mention the risk assessment of poor prognostic features that portend futility in care. We need to look for STEMI versus no STEMI on the ECG, and we have to address target temperature management, and in limited cases, the use of ECMO or eCPR. Over a course of many different registries, which is about 6 or 7 of those, certain factors have come out that suggest there will be futility of care. One of this is arrest sitting being unwitnessed. The next is no bystander CPR. Third is CPR more than 30 minutes. The next is initial rhythm not being VT or VF. Next is pH less than 7.2, and then lactate more than 7, and age greater than 85. Consistently, these factors for overall in all these different settings or registries have shown that these factors ought to be looked at in assessing futility. Let's start with each one of those. If you take patient with dialysis, end-stage renal disease and dialysis, they have a high incidence of arrhythmia and cardiac arrest with a very high mortality. This was verified to the International Cardiac Arrest Registry to be true. What about rhythm being non-VT VF? If you look at patients with ventricular tachycardia versus ventricular fibrillation, survival to discharge is around 35 to 40%. But if you have PEA or asystole, survival is very low at between 10 and 11%. Again, verified to the Intercar registry. If you have acidosis pH of less than 7.2, there's a poor prognosis post-resuscitation. Again, verified by the Intercar registry. If you have CPR less than 16 minutes, as I mentioned earlier, you have favorable prognosis. More than 30 minutes, your mortality is very high. So ongoing CPR, we don't take the patient to the cath lab. There's just no survival with those patients. You might have seen dramatic videos and people just thumping on the chest and going to the cath lab. There's just no survival in those patients, and those patients should not be taken to the cath lab. No bystander CPR. So I mentioned if there's a witness arrest, if you have bystander CPR, your mortality is at 32%. If you have no bystander CPR, mortality is very high at 68%. What about cerebral performance category? You have to mention that. The positive outcomes are CPC 1, which is full recovery with very mild disability, and CPC 2 with moderate disability. But once you get in CPC 3, 4, 5 being dead, you really have very, very poor outcomes. If you look at patients with more than 30 minutes return to spontaneous circulation, if your time to ROSC is 14 minutes of good survival, non-survival time to ROSC is more than 20 minutes. If you have, what about neurological outcomes? If your time to ROSC is again 13 to 14 minutes of favorable CPC 1 to 2 outcomes, versus more than 20 to 22 minutes, your outcome is very poor. Again, a return to spontaneous circulation get 30 minutes. Again, another study, again, very, 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 very high death rates compared to 0 to 15 minutes where survival might be 82%. Time for EMS arrival, if your ambulance arrives within 6 minutes or so and you get to the hospital in 30 minutes, and your ROSC is about 18 minutes or so, you have better survival than a delay in the hospital arrival time. Again, verified within CAR registry. If you have unwitnessed arrest, forget it. Your chance of survival is almost nothing. And again, verified with the INCAR registry. What about lactate? This is from the Paris ProCat registry. If you have lactate more than 7, your survival rate is very poor, and with a high mortality at 42%. From Australia, there's a combination that looked at both pH and lactate. If you have a pH less than 7 and lactate more than 7, your survival rate was very, very low compared to those who had pHs more than 7 and lactate less than 7. What about age? There's a curve that patients say above 70, 75, 70 going to the 80s, they have very, very poor survival. And again, this was looking at cardiac arrest populations, that's patients above 75, whether they got a PCI or not, survival was very, very low. So it's been about 10 years, and both Mike McDaniel and Neil Dickert were on this paper with me. We put up this algorithm. Why did we do this? Because for some reason, when the previous guidelines were written by the ACC/AHA for manual STEMI, the implication was that patients' cardiac arrest should go straight to the cath lab. And I can't tell you how many times you have patients from nursing homes with contractures, patients with kidney failure with potassiums greater than 7, or patients severe anemia showing up at the cath lab door, and whether you instrument them or they would even do a procedure, again became our mortality. So the cardiology group felt that we should have some kind of formatted idea about whom to take to the cath lab, and the task was given to the Interventional Council to publish this paper, which actually became very popular and gave us a better understanding of who to take to cath lab and who to not, and who to assess. And this was also very popular in the emergency room. So anyway,
¿Cómo se llama?
at that time, the algorithm was as follows. Patients who have had cardiac arrest but have ROSC, within 10 minutes hospital arrival, you should perform a 12-lead ECG and should start target temperature management with mild therapeutic hypothermia. This has changed. We'll address that in a bit. Those with no ST segment elevation have the acronym ACT, assess for unfavorable resuscitation features, consult with interventional cardiology, and transport to cardiac cath lab if indicated. Those with STEMI, again, we look for unfavorable resuscitation features. And this was basically, again, to the same thing we just discussed: unwitnessed arrest, initial rhythm, non-VTVF, no bystander CPR, greater than 30 minutes to ROSC, ongoing CPR, pH less than 7.2, lactate more than 7, age greater than 85, end-stage renal disease. Those patients we felt were less likely to benefit from coronary intervention. And individualized assessment by interventional cardiology was strongly recommended before we took patients to the cath lab. So people ask me after this, well, how can you be sure? How has this been verified? Are there trials? Well, cardiac arrest trials are very difficult to do, but the INTECAR registry fortunately verified all of these unfavorable features. And we published this in 2021, that what is a predictive tool for survival? We looked at all the factors that we just mentioned. The predictive tool for less than 10% survival to hospital discharge was age greater than 85, greater than 30 minutes to ROSC, and non-shock cardiac arrest rhythm. Or any combination of 6 of these, which included unwitnessed arrest, no bystander CPR, pH less than 7, lactate more than 7, age again greater than 85, greater than 30 minutes to ROSC, and non-shock initial rhythm. We also felt the patient had less than 2 unfavorable features. Say, if your lactate was more than 7 and you have had ROSC less than 30 minutes, you're probably a favorable candidate with survival more than 40%. But if you had more than 3 unfavorable features, as discussed, your survival rate was less than 40%. So you got to look at all these things before you think of taking people to cath lab. So a number of scoring systems are available, including ours that I just mentioned, the Miracle 2 score and the CAPS score out of Europe. The problem with these scores is very difficult to look at and calculate and figure out and come out with scoring numbers. And so you've got to make a quick decision when you go to the cath lab. So what we have done, for example, in Decatur, we look at all these unfavorable features and put a dot phrase note and an epic that we look at. I feel strongly that patients who come with cardiac arrest who are STEMI on the ECG should be assessed by interventional cardiologists. And if the patient is declined, we should really put in the data, talk to the family, tell them the morbidity and mortality is high, the outcome for neurological outcome is going to be really poor, and the chance of survival is poor. So we have put this up there, and we look at EKG with ST elevation, no ST elevation, where the patient has all these factors that we talked about: dialysis, rhythm, acidosis, CPR, unwitnessed arrest, lactate, and age. And then we put down a note that the patient's expected survival is probably less than 10%, as the patient is not a cardiac catheterization procedure. So we document why we're declining this case. Now, let's look at 2 different categories: patient with out-of-hospital cardiac arrest who has ST segment elevation on the ECGs. Patients who have achieved ROSC and are not comatose should follow the usual STEMI activation pathway, and the first medical contact blue metrics are as the same for usual STEMI care. However, comatose out-of-hospital cardiac arrest patients who achieve ROSC should be assessed for futility and follow these class 1 recommendations. I'll tell you, futility will be addressed over and over again as more documents come out. So the ESC has a class 1 recommendation that these patients should be strongly recommended to go to the cath lab. On their footnotes, they have said, again, futility should be addressed. Last year, the 2023 American Heart Association came out with their own guidelines and a document, cardiac arrest in the cath lab, which stated that, again, a class 1 recommendation should be coronary angiography should be performed emergently for all cardiac arrest patients with ACS suspected cause of arrest and ST segment elevation on the ECG. What about those patients without ST elevation of ECG? Five different trials have come out in this sphere. The big ones are the COACT and Tomahawk. And these trials showed that if you delay angiography versus emergent angiography, there's no difference in the outcome of these patients. Even though in all these groups, about 30 to 40% of patients underwent a PCI, there's no different outcomes whether they did emergent angiography or delayed angiography. And just recently, there's a Bayesian analysis of both the COACT and Tomahawk trials that was published that showed there's a harm with immediate angiography in patients with no ST segment elevation and out-of-hospital cardiac arrest. So the European guidelines now state that in cardiac arrest and out-of-hospital cardiac arrest patients who have no STEMI, routine immediate angiography after resisted cardiac arrest is not recommended in stable patients without ST segment elevation. And the American Heart Association says the same thing. Now, so what about target temperature measurement? So a trial came out in the New England Journal of Medicine, published back in 2021, known as the TTM2 trial, which was targeted hypothermia versus targeted normothermia after out-of-hospital cardiac arrest. And they found no difference. Hypothermia did not lead to lower 6-month incidence of death than normothermia. The current goal, as discussed in the European guidelines, is temperature control so that fever is prevented. And fever is described as temperature greater than 37.7 degrees centigrade. So temperature control is recommended for out-of-hospital or in-hospital cardiac arrest survivors who remain comatose after ROSC. And the OHCA says the same thing. We recommend selecting and maintaining constant temperature between 32 and 37 degrees during post-arrest temperature control. And we recommend that the hospital develop these protocols. And neurological assessment, I'll not go through that, as recommended after 72 hours. What are the poor outcomes on patients who have had cardiac arrest and have undergone PCI? All three parameters, mortality, bleeding, and acute kidney injury, increase in patients who are comatose. So comatose, if you have continued coma, even if you do a PCI, all these parameters are increased. Now, let's talk about ECMO. We've seen images of patients being candidated for ECMO in the Paris subway station or in the Louvre Museum. And this from the Paris registry said, well, there's a between 8 to 29% or so survival rate. But who were the survivors? They're mostly male, patients less than 60 years of age, and they received ECMO. So these are the three groups that appear to benefit from these very aggressive cannulations in the subway station or the museum, etc. What about ECMO trials, the ECPR trials? So one trial, very aggressive trial from Minnesota by Dr. Yiannopoulos, who has written a lot about this, and actually has a mobile ECMO van. This is also called the ARREST trial. The mean age is 59. Patients who didn't get ECMO did not survive. Those that received ECMO had 50% survival. And again, the neurological assessment appeared to improve over time in a 6-month period. On the contrary, in Europe, in the Prague out-of-hospital cardiac arrest study group, again, the mean age around 58 or so, showed no difference between conventional CPR, which was standard strategy, or invasive with ECMO. No difference at all. So if you look at trials which are not more than 600 patients in total, there might be a slight advantage to have an ECMO in the appropriate patient if it's available to you. So I redid this algorithm from 10 years ago to state the following, that out-of-hospital cardiac arrest patients achieve ROSC should get an ECG within 10 minutes. And if you have no ST segment elevation, according to the guidelines, defer emergency coronary angiography and watch the patient. If you have a patient in the appropriate age group who has no ROSC after 3 shocks or 10 minutes of CPR with 1 shock, if there is an ECPR facility available, and the patient is suitable for ECPR, and I don't know why the American Heart Association said the age less than 75, I think the age should be less than 60. The patient has features of witness arrest, absence of significant comorbidities, initial ECMO within 45 minutes, and has a mechanical compression device, a Lucas device, thumping the chest as the patient is being transported. He may have a better survival. He should go to the ECMO facility. If the patient has ST segment elevation, you should look at these unfavorable resuscitation features. Now, basically reworded in an acronym known as DRACULA, with D for dialysis, R for initial rhythm being non-VFVT, A is for acidosis, C is for no bystander CPR, U unwitnessed arrest, L lactate greater than 7, age greater than 85. So this mnemonic, I wanted to make it easy for people to remember. I actually presented it, national meetings published it. So if you go to the ER, remember this acronym, and you can make a quick decision based on, so it's an easy thing to remember. I know I'm making light of the situation, But I think if you think about it in your mind, these are things, if you remember the acronym, you'll know which patients to look at for purposes of futility. So survival after out-of-hospital cardiac arrest remains low at 10%. Clinical trials are difficult, inappropriate with small survival groups. Reliance are usually on registry and observational data. And poor prognostic features must be assessed for futility before a patient is taken to the cath lab. But I'll tell you, in future documents coming out from Europe and elsewhere, this is being addressed very aggressively. So when to activate the cath lab in cardiac arrest patients? So if you have a resuscitated cardiac arrest patient, ROSC, and the patient is conscious and not comatose, the STEMI on the ECG, this is definitely code STEMI activation. The patient should follow normal STEMI guidelines with STEMI metrics of first medical contact to balloon time. If you have resuscitated cardiac arrest patient with ROSC and the patient unconscious STEMI on the ECG, you should consult interventional cardiology, who should assess for unfavorable resuscitation features. ER does not need to activate the cath lab. It's no longer a dose balloon metric. Interventional attending will activate the cath lab as indicated. If a resuscitated cardiac arrest patient has ROSC, but there's no STEMI, activating cath lab is not indicated the class 3 guideline recommendation. If there's a cardiac arrest patient, in my mind, age less than 60 with CPR less than 30 minutes, candidate for eCPR, then we should get a cardiology consult to get an ECMO device. Now, how can we improve survival? The only way we can improve survival is really having AEDs available. And if as a nation we want to talk about it, if we can reduce AED costs by having mass production, like we did with the ventilators in the COVID pandemic, and have it available, and if insurance carriers and have the thing at low cost, $100, $200, like a car battery or something like that. Maybe the car batteries are more expensive now. But if the insurance companies, or if just like if you have a fire extinguisher at your home and you get insurance discount, if the insurance companies can give you credit for this in your home, then you probably will be able to improve survival, particularly in rural communities. So it's very important that if you get a shock in 4 minutes, your chance of survival is 60%. And with 8 minutes, the additional life saved. But you wait an ambulance to come, particularly in rural communities where it's all voluntary, patient is not going to survive. So what is the future? There's actually a project going out in the city right now, in Forsyth County to go onto Sandy Springs, where the company knows Avive, which makes AEDs. And this is only commercial. I'm not advertising this, but I'm telling you what's happening right now. Basically, if there's somebody cardiac arrest, bystander calls 911. The 911 dispatcher alerts the person or provider who is AED. And in this case, these are basically the EMS services where providers are provided with AEDs. Within 1 minute, using a rideshare-like app, the responder who's the closest to the patient, who is identified through the app, will bring the AED, to the patient. And within 1 minute, the patient arrives, and the attendant to the arrest patient can have this AED applied to the patient to provide a defibrillation. While waiting for 9 minutes for the ambulance is really, really, really long. So the other study that came out, published in JACC, was the delivery of drones within 5 minutes. 48 rural North Carolina counties, all first responders providing AEDs. There are a network of AED carrying drones, and this study was really 2013, 2019. And Brian McNally and CARES Registry were involved in this. And what was the outcome? So if you had providers who had AEDs, and if you had a drone available, if you could get to the patient within 5 minutes, your survival increased. So the median response time of a combination of either drones or providers who had AEDs with them, such as firemen, policemen, ambulances, if you could get them within 5 minutes, that was great. The outcome was great. And if you could look at this, the survival, if you got to them within 5 minutes, survival in witness shockable arrest was significantly improved. Those with just witness arrest, again, survival is greatly improved. And if you get to them with 5 minutes, that's where your 5 minute mark helps. When 6 minutes, if you get to the patient, that really helps survival. So what is the future? The way I think of it now, if you have a patient with cardiac arrest, the bystander calls 911. The 911 operator sends out a message which is picked up by satellites, which can cover rural communities, or through cell phone towers to dispatch to a dispatcher, and or alerts a place which has a drone within 1 minute through algorithms, through computer-based algorithms. You can find a drone or through a rideshare-like locator app, find the person nearest to you who has an AED. And that rideshare driver, and one of the ideas has been to provide this to people who drive on Uber or Lyft, if they're closest to you, because they have the app available, where you can be located within minutes to bring the AED to the patient within a minute, and or a drone to the patient to drop the AED, and you can improve this survival. So in conclusion, enhanced survival and good neurological recovery by prompt AED delivery and defibrillation is the key here. And we have not addressed this. This is the highest numbers of deaths in this country. Still, we are not addressing it properly. We should reduce costs from $1,400 to maybe $200 and make disposable AEDs available that are currently being tried. Multiple unfavorable resuscitation features predict poor outcomes after cardiac arrest. These patients should not benefit from going to the cath lab. However, patients stemming in post-resuscitation ECG should be aggressively evaluated as they derive the most benefit from emergent angiography intervention. And thank you. This is my presentation. I'll ask Brian McNally to provide a few comments now about the CARES registry and what his thoughts are. And Brian, once again, runs the National Cardiac Arrest Registry. Thank you.
Yeah, thanks, Dan. Great presentation. And, thanks for going through that. I learned a lot myself. I agree with everything you said. I mean, it is about doing the basics. And I think that's what we've learned with the registry. My former boss and still mentor, Art Kellerman, wrote an editorial several years ago saying, we know what to do in out-of-hospital cardiac arrest. We're just not doing it, meaning, we're not executing the basics that we know matter, the things that we know are impactful for survival. When we began the registry almost 2 decades ago, everybody was looking at an 8-minute response time in the ambulance. That was the metric that people were looking at. It was about the trained professionals getting there. But when you look at the chain of survival, right, those first 3 links in the chain are the community. Early activation in 911, early bystander CPR, early, hopefully, public access defibrillation. So the metric that I think is most important today is time to hands on the chest. And through telephone CPR education with 911 dispatch centers and metrics around that, that's where we believe there's going to be the greatest benefit. Getting AEDs to a patient, absolutely. But as you mentioned earlier, right, 75 to 80% of these events occur in the home. And if you look at the PAD trial data from more than a decade ago, they did not achieve statistical significance. However, if you can put these devices and the cost point is lower, as you mentioned, clearly that's going to provide an opportunity. But CPR really needs to, start in advance of that AED arriving, even if it's a publicly accessed device. I can tell you local data, without mentioning 911 services, when someone calls 911, the median time to first compression, meaning when the dispatcher is providing instructions to the caller to start CPR, is 5 minutes. The national standard should be around 90 seconds to 2 minutes. So there's a huge gap there. And a lot of other centers, a lot of other large cities are likely no different than the metro area here. Those are the metrics I think that really are going to make an impact. We've seen communities like Chicago. Chicago in 2014 had a bystander CPR rate of 15.5%. Last year, their bystander CPR rate was 55%. And how did that happen? They measured, and each year they did consistent training with their 4,500 firefighters. They changed their protocol to stay on the scene longer, to do high quality CPR. They changed their dispatch process. They did community-based training. So there's good examples of communities that have resource challenges, like Chicago, like New York, and others, where if you focus on the basics and you get hands on the chest sooner, and you provide quality basic life support in advance of advanced life support, you can make a difference. So I'll just stop there. But I think that's the future, is communities beginning to look at how quickly are they starting. And I think a lot of you on the call, right, that particularly those that are interventionalists, when the patient arrests on the cath lab table, right, and you start CPR, you often will see the patient waking up, right? This is exactly what we're seeing with 911 dispatch centers that have changed their protocols to start CPR sooner, or looking at doing quality improvement. A colleague that runs Anchorage Fire Department told me and has presented on this. They changed their process several years ago because it was taking too long to initiate CPR based on their protocol. They changed their protocol, they did QA in the process. And they had many cases where the fire department arrives on the scene and they get on the radio and they call and they say, this is not a cardiac arrest. They tell the family members to stop CPR because the patient's awake. And as soon as they stop CPR, the patient goes back into cardiac arrest. So this is the same thing that you see in the hospital, because you're starting CPR so soon, the patient is perfusing their brain and they're conscious. So these are the anecdotes that you can see are happening, where time to first compression is occurring much more proximate to collapse, which is what we need to do. 5 minutes or waiting for the ambulance to get there at 8, 9, 10, 12 minutes, you know the outcome, as was described in this lecture, is going to be a lot worse. So I think that's the future, is focusing on the basics, and continuing to educate the public.
So Brian, what about cheap AEDs that are being made available? You know, they're being developed, these disposable ones, provide 3 shocks. And if we, if we give, as I talked about, if insurance companies give you a break, or like a fire extinguisher in your home insurance gives you a break. I mean, if we mass produce these, don't you think it'd be helpful, particularly in rural communities?
Yeah, absolutely. I mean, there's no question about it. Getting the device quicker to the patient, just what you described, the future, looking at a mobile response, putting it, whether it's in a Grab, or I'm sorry, whether it's in a Uber, or whether it's in Lyft, or whether it's a drone. It's really a dynamic model, that device, being integrated with the 911 system, so that as soon as the dispatcher is telling the bystander to start CPR, they can look on their screen to see whether it's Pulse Point Activation, which is the company that ties together the dispatch center with the device, or community member to get the device and bring it to the patient's house. One big difference in the US for safety concerns, the application Pulse Point, which is again tying a bystander that's signed up for the app to go to a neighbor's house. They're not going to dispatch for an arrest that occurs in a residential house in the US because they're afraid of safety concerns. So they're only going to dispatch for the 20% of cardiac arrests that occur in the public. My colleagues that work in Singapore and Korea and elsewhere, they dispatch on all. They're not concerned about safety, or I should say they're more concerned in the US about safety or liability. So there's a disconnect. A lot of those systems are using off-duty firefighters or off-duty police that sign up to be able to go into that house because they've received training and they feel that they can go into a house. So there is a little bit of a disconnect in terms of getting that AED with that app to get into a patient's house, where again 80% of these arrests are occurring because of liability and safety concerns. Singapore has a much smaller community, about the size of Atlanta, population base. They have many more cases that they've documented where the patient is being successfully defibrillated by the community member because they're going into the residential setting, which again is not happening in the US, at least with non-trained providers. So you can see that that ability to get that device there sooner in the community, where the algorithm allows for it. So there's definitely some limitations, as I mentioned, related to safety, but again, the mechanism around it is train providers that are off duty that have that device in their car, to respond. I think without the bystander CPR piece, right, you're missing a huge opportunity. And I think hands on the chest really is going to allow, however that defibrillator gets there, is going to give you a greater chance of success of having a shockable rhythm.
Stan Sherman, has there been any data that teaching CPR and defibrillation all in schools has made a difference?
It's a good question. There is some data, and actually CARES data, that looked at states that legislated mandatory training in schools for states that didn't. Obviously, not all states have signed on to the legislation. There are some limitations in the study in terms of time sequence, but there was at least a suggestion or an association that states that had legislation about bystander education had higher outcomes. Again, an association, not correlation. I think we'd all recognize, the challenge often is that someone takes CPR course, they may never see a patient in cardiac arrest in their lifetime. So, and if they've had, that muscle memory, a lot of people, bystanders, even that have been trained in a CPR course, will not recognize cardiac arrest. Again, why the dispatcher piece is so important. Reinforcing community-based training, agonal breathing, which is very common, as you would understand early on in after collapse, often is confused as, the dispatcher used to ask, is the patient breathing? Now the dispatcher needs to ask, is the patient breathing normally? Is the answer no, and they're unconscious, obviously we need you to start CPR. And they used to ask, would you like to start CPR? No one wants to start CPR. Now they say, I need you to start CPR. I'm going to coach you. I'm going to stay on the phone with you. So there's sort of been a paradigm shift in terms of how the dispatcher needs to take a more active role and trying to gain control of the caller, which often, again, as a family member, and this is a pretty emotional event, as we'd all recognize. So the training that goes with that and the quality improvement to learn, how often is that dispatcher recognizing cardiac arrest? What is the median time to first compression? Providing individual feedback. So, but again, to get back to your question, there is some association. And I think that muscle memory of CPR and prompted by a dispatcher later or years later, hopefully will provide, a greater understanding of what to do.
Any other questions, guys?
Question for you, Tanveer. So, it was interesting that the initial factors for cardiac arrest, you made a point of, it said no history of calcium channel blockers. Do we make anything out of that? Is that just
I
a
don't know. I know that
statistical
article
thing,
that
or?
it was very confusing why they mentioned that, but they didn't give it quite an explanation in that article. That actually came out from the Japanese literature, and I really prodded that article. But I think the other things are quite relevant, in terms of risk factors, cardiac arrest, pretty kidney failure and young age, and we see that in our rural communities quite a bit.
If it was Japanese literature, I'm just wondering because they're so in tune with vasospasm and calcium channel blockade. So I'm just wondering if that's why they specifically looked at that.
Probably.
Okay. Well, thank you so much for
Thank you very
the
much.
amazing review, and really appreciate your time. And everybody, don't forget to get your CME, and I will see you next week.
The preceding program is copyrighted by Emory University.